communicable diseases are still very important, and the health system is very much orientated to that kind of reactive response to care, and needs to transition towards being able to supply care that will meet the needs of people with chronic disorders. There is some vertical programming. So for mental health we have a strategy, there's an NCD strategy, there's almost no crosstalk between the two of them. And we've been working for the last 7 years to try and integrate mental health into primary care, and lots of that has been very successful. But one component that has been particularly challenging is trying to get a vertical programme of depression into primary care. And the particular challenge has been detection in the health centre level. So then where do the opportunities come? So with the PAC guidelines, the Ethiopia Primary Healthcare Guidelines, these are a different way of presenting guidelines to primary care workers compared to the vertical guidelines. So for mental health, the primary care worker has to first understand that depression is present, and then they can follow the algorithm, and that's fine. But the difficulty is, of course, getting into the algorithm. So the big opportunity I think we see with PAC is that because it's so integrated, every part of all of the pages of PAC kind of lead you to mental health. So I'll just flip forward. So headache, for example, takes you through emergency headache presentations, and then you go through and there's mental health. You've got to screen for mental health. And headache is the most common presenting complaint of depression in Ethiopia. So that's a really important way to us to get in for depression. So I think that's what I understand by integration in particular. As I say, we've been doing a lot of work trying to integrate into primary care, and so I think that implementation research experience is really helpful. And this policy emphasis on quality of care, as opposed to just improving access to care, and on the kind of sort of interaction with clinicians, I think is really helpful climate within which we can work in asset. So what can we add? As Martin had in the original protocol, he'd sort of drawn out the key functions on a care pathway needed for optimal outcomes for people with chronic conditions. So detection, engagement, adherence, retention, and treatment to target. So they fit, I think, very well with what we're trying to achieve in this part of our asset work. We've got the primary healthcare guideline as the kind of tool, and then around that we need to sort of strengthen the health system to be able to do all of those different functions of the care pathway. And as I've indicated at the moment, for depression and for many of the NCDs, which have not really been managed in primary care health centres across Ethiopia at the moment, I mean, we're even talking right at the beginning of the care pathway, and even before people get to the facility, a part of the problem. So, as has been said, there's already been a lot of work to do the contextualisation, and the Ministry of Health is going to start implementing. So the training cascade has begun this week, and Laura's going to show us some photos later, hopefully. So we've got the training of the master trainers, and that's cascading down. What we want to do is to get these guidelines implemented in our districts where we're going to be studying, and sort of just done as the Ministry of Health is going to do it. And then we let that be embedded, and then we start to do our diagnostic phase of asset, where we start to understand, well, taking that approach, where are the areas where we could still strengthen and improve outcomes? So our diagnostic phase takes a similar kind of pattern across all of the three platforms that we're working in. So we want to understand the health system bottlenecks to achieving sort of optimal NCD, integrated NCD mental health care, and what sort of health system strengthening interventions are appropriate, feasible, acceptable, how would we implement them? So the setting is in south-central Ethiopia, and it's a place where we've been working for quite a long time. There's a health and demographic surveillance site, which has been up and running for more than 20 years. And a lot of mental health studies have been taking place there. And that covers 2 districts, and there's a 3rd district where we've been working with the Prime project, which has been led by Craig. And that gives us a total population of about 300,000 people. We've got 2 hospitals, one general, one district level primary hospital, 18 health centres, and we have approximately 200 of these community-based health extension workers. And the topography is quite sort of diverse, so there's lowland areas that are really dry and hot and have quite high mortality and much worse health indices, and then the highland areas are quite, luscious and sort of fertile. But still a very high population pressure actually, so still problems of food insecurity even in the more fertile areas. So we're going to start with stakeholder workshops and consultation, and that runs through the diagnostic phase. So as we get more information, we'll be going back to selected groups of stakeholders. And we'll use the theory of change approach, which we've been using for our mental health work. And this is what you get with theory of change, and even this is a simplified version. Yeah. But of course, I mean, we are dealing with something extremely complex. So the beauty or the usefulness of theory of change, I think, is it does try and give you a working model. It gives you something to hang your hat on and sort of, because otherwise it becomes impossibly complex and you can easily get lost. So the theory of change map will allow us, we start from on the right-hand side, what we want to achieve. And then it's a process of working back. To achieve that, what do we need to achieve? What's the thing we need to achieve before that? What's the intermediate outcome before that? And you go back. What are the interventions that are needed to achieve each of those different outcomes? What's the indicators of success? So it helps not just to plan your intervention, but also to plan your evaluation. And what are the assumptions, critically? What are the assumptions on which you're making this assertion that this is the roadmap to achieving your outcome? And they form those, when you articulate those assumptions, they allow you to identify the barriers, the potential barriers. And so the diagnostic phase can, if we start with this, the diagnostic phase, we can make sure we'll be in depth enough and able to kind of explore those barriers and how much they will jeopardise what we might be trying to do. So another thing, just one more thing to say is, I mean, it is massively complex. One important thing in the diagnostic phase is also to understand which of the pathways are the most crucial, where are the leverage points, and where are the key indicators. Because you can end up with a list of 200 indicators and however many different assumptions, and they're not all equally important. So it is really important to kind of get that sense of where are the really important things to focus on. So after the initial stakeholder workshops will be, and well, actually somewhat in parallel, we'll be collecting publicly available data in the districts that is relevant to NCD and mental health care. And we'll adapt a situation analysis tool that we've been using in the PRIME project. And it's basically structured along the health system pillars. So it has something about, what are the policies and plans operational at the district level? What are the human resources and what's their level of training and who's deployed where and how much of the time are they available? Medications, that kind of thing. So we can conceptualise these as the sort of structural underpinnings to being able to start the process. So if we don't have insulin, then we know that anything else we might do about quality improvement is going to be rather limited in its kind of impact. So we need these things are necessary but not sufficient for achieving what we want to achieve. Then there'll be a process of sort of hanging around health facilities and talking to health managers and just trying to map out the actual processes of care at the moment. What data is collected along those bits of the pathway, the detection, the adherence, the treatments target. We know we know there's going to be no information on treatments target, for example. But how do health workers know how many people have got NCDs? How many people have dropped out of care? Where are the deficiencies? Where could be improvements made? We'll do some documentary analysis of clinical notes. This is maybe a little bit hopeful because it depends on the quality of what's documented. But the idea is to try and look at adherence to the guideline. And then we'll do some observational study, and for this particular part of asset, we're going to use something called ENACT, which is a structured way of observing clinical interactions. And it looks at communication skills, but it also looks at sort of the ways, it's quite good, I think, for capturing person-centred care. It asks people about, to what extent does the health worker ask for the views of the patient, understand their explanatory model, understand their social context, their values, their goals, those kind of things. So I think it could be very useful. So we've been using that, and we've shown it can be reliably administered, and it seems to be useful, not just in its sort of total score, but in the patterns of deficiencies that we identify within health workers. So then we're going to try and plug a little bit of a gap in the Ethiopian literature. We've got quite a lot of community studies, but very few primary care, in fact no primary care level studies of non-communicable diseases. We've got sort of hospital level and community level. So first of all, to understand the burden of NCDs in sort of routine primary care, but importantly to understand the extent of overlap between the different NCDs and between depression and substance use problems. We're going to look at detection, so what percentage of these are detected, and to what extent is the care person-centred. We'll be asking some kind of structured questions about people's experience. And we'll be, you can see here, these are some of the measures. So the sample size around 2,000, I've not put any kind of detail of the study design because I just want to give a framework on which we can hang detail, and then we can start looking at that perhaps tomorrow. But of course, if you want to ask questions, please do. And then the qualitative study, again, will try to sort of flesh out people's... I think this is an opportunity where we might want to sort of go into even what is person-centred care, and what does that mean to people, and what are people's expectations of care when they have a chronic illness, what are their needs. That, I think, but also to understand how they track through the pathway, where things don't fall apart, you know, where they're not getting what they need, and also from the health worker perspective and the manager perspective as well. So what are we looking at in terms of possible health system strengthening interventions that would be particularly relevant? So we've got this clinical communication skills module, which, where's Inga gone? Yeah, Inga sort of led the design with lots of other people for Emerald. And it syncs in with the kind of teaching approach of the Ethiopia primary care guidelines. So it's sort of facility-based learning. But it covers not just communication skills, which are important, but also this issue of change management, how to handle emotional content within sort of patient-clinician encounters, and just how to kind of think about the patient-clinician relationship and needing to be more of an equal relationship to enable self-management in patients. So we think that could be very important, and they've been testing it and using it in South Africa. I think it's a good fit for Ethiopia with some adaptation. I think information tracking by the mHealth sort of approach that's going to be a really good fit for this part of what we're doing. The learning health system approach, where we have service user involvement linked with the information that we're getting from the mHealth in a kind of quality improvement process, I think that will be important. And we might want to think about management leadership and how we want to strengthen that as well. So after that, we'll obviously synthesize the diagnostic study findings, and that will lead to final theory of change maps. And then that leads on to the piloting phase and the evaluation phase. And we envisage this part of ASSET in Ethiopia to have sort of 8 health centres with the interventions and 8 without. I have some questions about how we unpick the contributions of specific health system strengthening interventions. I'm not really clear about, you know, if we do all in some health centres and none in others, you know, and then we get that improvement, how do we know what's really helping? So maybe we could think about that. Just to say, we've already got a PhD student, Andrew Allen, who's going to be linked to ASSET. He's funded through the Wellcome Trust Amari programme. We've got lots of other ideas for capacity building, so be aware. So what I'd like to say in conclusion is, I think really ASSET is absolutely perfectly timed. I really think it just, from my perspective, it's exactly what is needed. You know, we've just finished this huge bit of work in mental health, and this is really the obvious next step, but it also fits so well with kind of priorities of the ministry. And perhaps a specific area for discussion, as well as the one I've just raised about how we disentangle evaluation effects, is really about what person-centred care is all about and whether we can really transfer models from the West.